Hello, dear colleagues. My name is Dirk Arnold. I'm Medical Director of the Askleckers Tumor Center in Hamburg in Germany. And I do have the pleasure to report here from ESMO 2025 in Berlin, so the biggest European meeting in oncology. I had the pleasure to present data together with Andreas Sörse from New York about how to optimally manage patients with locally advanced rectal cancer. And that's really a difficult task, since we have many modalities which have to be combined. Surgery or definite ablative treatment, radiation treatment, chemotherapy, and also immunotherapy has been entering the field. So we had the pleasure to guide a bit of this discussion. And message number one is perfect diagnosis in the beginning is essential. So we have to do the radiographic assessment by MRI. We have to do the molecular assessment by having the MSI status and other molecular markers. And also, super important, we have to learn about patients' preferences and patients' symptoms, because the different pathways separate at some point according to patient's preference, whether we should follow an organ preservation strategy or whether surgical removal or surgical resection of the tumor is the goal. So having said this, what are the key findings? Well, we've followed various algorithms. Message number one, chemotherapy works, or systemic treatment works. And in general, when we talk about systemic treatment, we talk about substitution of chemorad by systemic treatment. And for early stage T3 and 0 colon cancers, this is a great option. And second, systemic treatment in case of MSI high is even the standard of care. Andreas Sörse has nicely shown us how well immunotherapy, specifically dostarlimab, does work, producing clinical complete responses in nearly 100% of all patients. So therefore, MSI high locally advanced rectal cancer deserve only treatment with immunotherapy and no surgical management unless they have some kind of residual tumor. Message number two, we may be over-treating some patients. The enthusiasm about total neoadjuvant treatment over the last years has led to so much application of these TNT strategies. And in fact, if we do the proper staging, and in fact, if we are not aiming an organ preservation strategy, TNT is a total neoadjuvant treatment, may be over-treatment in some patients. So it deserves a clear link to these guidelines and the decision criteria. Message number three, organ preservation is still an important goal, because we have learned that after TNT, following TNT, also in early stages, we can expect to have the clinically complete response, whatever this means in long term, in many, many patients. So therefore, if a patient is not favoring to undergo surgery, if organ preservation is the strategy, we have various options, starting with strong radiation therapy, then consolidation radiation treatment, then consolidation chemotherapy, and then maybe local ablative radiotherapy in the final end. So therefore, plenty of options. It is worth reading. NCCN guidelines do help you, and my personal take is ESMO guidelines will also help you and maybe guide you even a bit back. Having said this, thanks for listening.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.